Here you go, Gabe. You're on.
The first thing we should do is videotape everybody who's in attendance.
Should we?
That's
okay, let's see.
disgusting.
Let's see. Let's see, everybody. Oh, there's KJ. Oh, Jenna, you guys look beautiful.
Actually, I would actually
Come on. Oh, Kelly, look at the close-up.
I would prefer to see the reaction of my words on everybody's faces.
As we go like this.
As you go like this.
Muff, what?
Oh, my gosh.
Well, I guess our presumptive topic would be what happens in the OR as a potential conversation piece for this morning. It's something I usually like to talk to the fellows about, since although I'm not a surgeon, we're not surgeons, a lot of stuff we're dealing with is obviously a reaction to what the folks did downstairs in the OR, and understanding a little bit about that can help us understand, why some of the side effects or complications that we see in some of our patients. So, does anybody have any specific questions about stuff you've been curious about, hearing on report, or fall in centricity as you're waiting for the patients to come back, anything like that? Or should we just talk generalized about stuff?
I'm kind of curious about how cold they actually get, and the difference between there's the cross limb, the surferus, the five-head time, all that.
Perfect. Yeah, that's exactly what I wanted to talk about. I think that's misunderstood by a lot of people, and especially the sort of our fellows when they're coming onto the unit. So I think it's really important to know what those different things are and what those times mean and why do we care.
Yeah.
Most of the times I don't care when they say them, but there's sometimes we do care for those different things. So, cardiopulmonary bypass itself obviously sort of revolutionized what we can do for kids with heart disease. Back in the 50s and 60s where people were very much researching this stuff. But before that, you could only do things that you could do when the heart was beating and having to utilize the patient's own heart and lungs to maintain blood pressure and oxygen. So they could do things like shunts and PDA ligations and even co-arc repairs, things that you could do from a thoracotomy or things like that where you don't need bypass. But before that, all these other patients had pretty much non-repairable heart disease. VSDs, ASDs, you couldn't do anything about it because you couldn't bypass the heart. But when Lil High and a whole bunch of people did some amazing stuff and designed oxygenators and bypass machines, then we were able to sort of launch and do all the stuff we're doing today. They tried a whole bunch of different stuff. They tried cross circulation, so get patient's father, patient's son, and hook them up. That was the bypass circuit. So they hooked up into the femoral vessels of the dad, and then used the dad's heart and circulation to bypass the son. They did monkey lungs, things like that as their oxygenator. So lots of crazy experimental stuff. But eventually we got to the systems that we have today, and we could actually do bypass. So, bypass is in its name. So, what are the main reasons we use bypass? We want to operate in the heart. We need to maintain circulation. So that's one of the key components that a bypass circuit does. It gives blood pressure to the organs that you want to preserve as you're taking that heart out of circulation, and it bypasses the lungs. So you have to have a way to oxygenate the blood that you're taking out, just like an ECMO circuit, has an oxygenator. The bypass circuit has an oxygenator too. So those are the two things you want to accomplish with the bypass system. And why do you want to do it? Again, you want to operate in the heart. You want the ability of draining the heart of blood. It's a heck of a lot easier to operate in the heart when it's empty. I don't operate in the heart, but I can imagine trying to operate with it full of blood. They actually did one procedure called the atrial well, where they would just sort of put a funnel on top of the atrium and allow the blood to sort of fill into the funnel. And then the surgeons would try to close ASDs by just putting their fingers down there, finding it, then putting that hemostat down there with a suture on it, and just start sewing things closed. And they're able to do that without bypass. That was sort of some of the first bypass techniques, but they really felt like they needed to get better exposure, better visualization to do things more successfully so the patients would actually live. They thought that was going to be a helpful component of their investigations. So you want to be able to drain the blood, and then also it's sort of hard to do a lot of the things we do on a beating heart at times. Hard to try to close a VSD as the heart's beating back and forth with your sutures. So having the ability of stopping the heart's function is important. So we'll talk about that as we talk about the different rest times and clamp times and things like that. Importantly with bypass, it's a huge circuit, sort of like an ECMO circuit with lots of tubing and pumps and things that are sucking blood and pushing blood in. So the key components are having a venous drainage. So you have to drain the blood that's coming back to the heart and prevent it from going in the heart. And you can accomplish that by, they do the sternotomy and dissect everything out. And they usually accomplish that with either a right atrial cannula, just like we see up here in the unit when we have patients on ECMO. Or sometimes they'll do a single cable, so they just do an IVC or an SVC cannulation. Or bi-cable is probably more common that we use. We'll put a cannula both in the IVC and the SVC to drain all the venous drainage coming back to the heart. We do that in our kids because we have a lot of structural heart disease, and there's lots of things we have to fix in the atrium. So having a big cannula in there can be cumbersome, and also you want to make sure you're getting all the blood drained so you can really empty the heart so you can see what you're doing. And then you take that out, run it through an oxygenator, run it through a filter so you can filter out some extra fluid if you want and hemoconcentrate things, and then pump it back into the aortic cannula that you just put into the ascending aorta, directly into the ascending aorta, or you can put a little shunt on there and then put it into the shunt and then into the aorta. So you basically are, again, all the venous drainage comes back into the pump, gets pumped out to the artery, so you're bypassing heart and lungs to accomplish our goals. So that's the first steps they'll do down there. They'll go down there after they do all their anesthesia and put lines in, TE probes, take their timeouts and figure out what they want to do. They'll dissect, and then they'll cannulate, and they'll cannulate their cava, and they'll cannulate the aorta, and then they can initiate cardiopulmonary bypass.
What if they have to do work on the aorta? Then where do they put the cannula at?
Talk about that.
Okay.
Talk about that.
Thank
That's
you.
a good question.
Thank you.
And it sort of comes in the sequence of sort of how we'll get to that point. So now we're on bypass, and at this time, is the heart beating or not beating? We're on bypass. It's actually beating. It's actually beating. So, and even if you're on full flow bypass, and unless you can get really great flows and completely drain the heart until it's like quivering because it has no blood in it, when you're on cardiopulmonary bypass, your heart is beating, and so it's just beating away down there. Say just like on ECMO, then you have pulsatility. You can just beat and do a good job. If you drain it completely, again, it can be so decompressed that it's not going to beat too much, but then it's going to be stressed, and then you're putting the heart under stress, and making it try to work when it can't really succeed. So the first steps that you do when you go into bypass, you still have a beating heart, but that doesn't accomplish our goals of what the surgeons want. They want a dry field, and they want a still heart to beat on. So now we have to do something else. And this is where we get into cross-clamp time. So you have your cardiopulmonary bypass time. That's the time when the cannula and venous blood has come through the pump and get pumped into the body. That's your cardiopulmonary bypass time. So that's going to be the longest time that we have. And so when the surgeons come back and get a report, that's always the longest time. I had 244 minutes of bypass time. 102 minutes of cross-clamp time. So what's cross-clamp time? Cross-clamp is when you basically cross-clamp the aorta. And you do it proximal to where your aortic cannula is put in the aorta. So that blood now can only go from your pump into the cannula and then to the body. All right, so the head, brain, important organs, and the rest of the body. But it can't go backwards towards the aorta. But what else comes off the aorta closer to the heart?
Coronaries.
Coronaries. So if you put a clamp on there, now you have no blood flow going to the coronaries. So your heart is at risk for basically having a heart attack, having coronary ischemia. So this is where the surgeons do something else to get their slow, non-moving heart. They give something called cardioplegia. So when you give cardioplegia, it's basically just a paralyzing solution. It's basically giving a big bolus of potassium chloride with a whole bunch of other little cocktails that people have investigated, like, oh, we should give amino acids, blah, blah, blah. And it's usually cold, so it's cold cardioplegia solution, but usually it's just potassium chloride. And so when you think about cross-clamp time, that's really what we think about as cardiac arrest time. That's the time when the heart is arrested. Doesn't mean that we're in circulatory arrest, which we'll talk about next, but that's when we're arresting the heart. So they put the clamp on, cross-clamp time, aortic cross-clamp, and then you inject this fluid directly into the aortic root, or in bigger people, you can put it directly into the coronaries, this cardioplegic solution, and then the heart goes. You guys probably aren't watching the monitor that early because you only care when the patient's coming up. Eventually coming up to you, but if you turn on the monitor from down to the OR in the beginning of the case, you'll see the nice narrow complex EKG until they put that clamp on and give cardioplegia solution that is like wide, complex, slow, and eventually just asystole once that plege solution works. The solution works for about 20 to 30 minutes if you give it as a bolus. Some institutions, not us, sometimes run like a continuous infusion. But a lot of times we'll have to give a bolus, arrest the heart for 20, 30 minutes, and then the surgeons might be operating and think, well, I'm not quite ready yet. We need some more time. Give me another bolus.
Where do they put the boluses, Gabe? Where do they give the bolus of cardioplegia?
So they put an extra cardioplegia needle in.
Okay.
That's, again, sort of proximal to where the clamp is, so it's not going to go to the body, it's only going to go backwards. And they put it in the aortic root.
Okay.
But when we're talking about different lesions, you might not be able to do that, especially the redosing. So we can take an arterial switch, for instance, that we've done here in the last couple weeks here. We just did one yesterday. They'd go on bypass and cannulate the cava and the aorta. Usually in this case, there's enough room where you can put the aortic cannula far enough away from the aortic valve that you can still operate on the aortic valve by doing the switch, just cutting it off, and you're still on bypass. And can still, the surgeons can still switch things around. So they can then they'll cross clamp, give a dose of cardioplegia, arrest the heart, and then go ahead and move forward the operation. But if they need to give another dose because there was a complication or things weren't moving as fast, now you don't really have the ability because the aorta is cut off from the valve. You can't really give cardioplegia to the coronaries anymore, especially in a little infant, because they're too small. You can't put a little needle directly into those coronary ostia because things are just too small. We're adults, you can just put coronary cardioplegia needles directly into the coronaries and perfuse it that way. So then we're stuck. But there's an alternative. We can actually do it retrograde cardioplegia. So we can actually give cardioplegia solution through the coronary sinus, or basically the big vein that drains the coronary blood flow, and just inject it that way. And then fill the heart backwards with cardioplegia solution, and again arrest the heart. So the purpose is sort of, again, the main purpose is to have a quiet heart to operate on. The second purpose of cardioplegia is to preserve the heart muscle at times when you're operating. So it rests it diastole. It's telling it, you don't have to work so hard, just chill out. We'll give you some nutrients in a little bit. But we don't want the heart struggling and becoming ischemic because it's utilizing oxygen and then going in anaerobic metabolism, causing those problems. So you can give it antegrade through the coronaries, through the aorta, or you can give it retrograde through the coronary sinus, and it sort of depends on the surgery you're doing. But when you hear about cross-clamp time, that's really cardiac arrest time. So if it's a real long cross-clamp time, that means the heart was arrested for a long time. And there's certainly what we call reperfusion injury that occurs. So the longer that cross-clamp time is, for me, when I hear that, I don't really care about the bypass time. The timing of that doesn't affect me. I think, whether you're on bypass for 5 minutes or 200 minutes, the systemic response the body's going to have with inflammation and clotting problems, things like that, is probably going to happen anyway. But as far as cardiac recovery, the cross-clamp time is important. You just really want to know if that was a real long time, the heart was getting cardioplegia and just hibernating. And then once you give it perfusion, it can have a lot of troubles waking up. That's where we get a little disconcerted. So those are the first two times. Yep.
What's a long time? Like what number makes you go, ooh?
Usually our cross-clamp times are on the magnitude of 40s to 70, 80 minutes, something like that. So a long time is something over 100 minutes.
Okay.
Cross-clamp time.
Okay.
So they can, we can do 2 or 3 rounds, of cardioplegia solution. So an hour and a half or so would be a long case, and that'd be something you'd be like, oh.
Okay.
I wouldn't be surprised if they were on a lot of support coming back out.
Okay.
So that'd be something that would sort of raise your antenna. And then the other time that we hear about sometimes would be the question about what is hypothermic circulatory arrest, deep hypothermic circulatory arrest. This is a different arrest time that we hear about. We don't hear about it all the time because most of our patients don't get this. But it has to do with when we can't operate with cannula in position, or we can't operate on the structure and be on bypass at the same time. And it's a situation where you said, how do you put an aortic cannula in if you want to operate on the aorta? So our biggest patient population where we want to do a big aortic reconstruction is what? Hypoplastic left heart syndrome, right? So these patients have these little tiny aortas, and they're supplied preoperatively by a ductus arteriosus, supplying their body, and that's why we keep them on prostaglandins. But the surgeons then need to operate on these patients and give them a big, wide aorta, neo-aorta, by sort of widening in the pulmonary artery with a tiny diminutive aorta and make a nice big aortic arch. Well, you can't really do that at the same time as you're trying to perfuse the head and neck vessels and the rest of the body on cardiopulmonary bypass. So you have to do something else. And so this is basically deep hypothermic circulatory arrest. Most of our patients have some degree of hypothermia. She just came back. Some degree of hypothermia in most of our cases. We probably, in pediatrics, we usually use a moderate hypothermia, where we'll usually chill down patients to 25, 28 degrees. for most of our cases. And that's really just to provide end organ protection and cardiac protection, but a lot of brain protection from that. But that doesn't really cause, too much sequelae. When we do deep hypothermia, we actually chill patients down to 18 degrees over a certain set time point. We've learned historically that you don't want to do it too fast. And same with the reborning process, but you're talking packing everything in ice and chilling the babies down to a little popsicle, about 18 degrees Celsius. So it's cold. And then what you actually do once you reach that temperature, you actually drain all the blood out of the body. It all goes into the bypass pump. You take your cannula out of the heart, and you're just frozen. So there's nothing going anywhere. There's no bypass going to the brain, no bypass going to the kidneys. You're basically dead. You're just cold. It's sort of the old adage, you're not dead until you're warm and dead. That's sort of the ER uses. If a patient drowns in the middle of winter, and they come in, they're pulseless, they're not breathing, well, they're not dead until they're warm and dead. And this is, they're basically just, arrested circulation. And you can do that, quote unquote, safely for, up to 40 minutes or so. Over 40 minutes, we start seeing that there are some long-term neurodevelopmental complications or even some acute increased risk for seizures and other complications. Over 60 minutes surely is more robust data to support. You don't really want to have circulatory arrest times much above that. We have some of the shortest circulatory arrest times for Norwoods in the country, which is good and probably helps some of our outcomes for sure. But it gives the surgeons the best operative field to work on because it's bloodless and it's still. You just have to be fast.
Do we do that here?
Yep. So we do that on all of our Norwoods. Any of our sort of long, from the front arch reconstructions. So not the discrete coarctation that they can go from the side, but when they have to open up the front and go from the middle, they have to do that. Again, it's just because there's just no room to put a cannula when you have to take the arch apart and put on patches.
I didn't know all this.
So
This is interesting.
But so that's usually the highest percentage of patients that we do it on would be the Norwood or single V arch reconstructions or those sort of long segment coarctations. Another patient population that we'll see deep hypothermic circulatory arrest on is our obstructed veins, obstructed total veins. Our institution will usually do circulatory arrest, and that's mostly not because you can't cannulate the aorta, but even when you're doing a great job draining blood and bypassing the heart and lungs, you're still going to get some bronchial blood flow. You're still going to get some blood going to the lungs and then coming back through the pulmonary veins. So if you're trying to reanastomose the pulmonary veins back to the heart and you have any type of blood coming back, it just sort of clouds your surgical field. And so our surgeons most of the time will go ahead and go under circulatory arrest and just say, let's just get a clean field and operate quickly and then slowly rewarm. When you rewarm from circulatory arrest and you put your cannula back in, you get back up to where your heart's still arrested because you gave cardioplegia, but now you can be back on bypass, and then you allow things to reworm further, and now you're back on bypass, and then you eventually see if you can separate from bypass. So besides those patient populations, we don't do a lot, and not every patient gets circulatory arrest, and that's probably the biggest confusion I see with our fellows is that when they hear cross-clamp time, a lot of people think that's circulatory arrest, or they hear cardiac arrest time, they think it's circulatory arrest, but it's a big difference because it's a huge risk from a neurologic, side effect and complications. I mean, even so much so that they said this doesn't seem like a smart thing to do, guys. Right? We should just freeze patients down and operate really fast and not give their brain any blood. That seems stupid. So people decided that maybe we should try to just perfuse the brain. We know we can't put a cannula and perfuse the whole aorta and the rest of the body, but maybe we can just put a reperfusion cannula you see on ECMO to the leg. Why not do sort of a reperfusion cannula and just run bypass to the brain and protect the brain? And so there's something called regional cerebral perfusion. So you basically just cannulate one of the head and neck vessels, the abdominal artery or one of the carotids, and just perfuse the brain. Instead of chilling down to 18 degrees and having no circulation, people thought we could just do this sort of selective perfusion of the brain. So they did a big randomized trial and tried to show that this was better than freezing Dr. Goldberg here was sort of the primary investigator on the Boston circulatory arrest trial, but didn't really see any major differences in either cardiac outcomes, ICU outcomes, and then most importantly, any type of long-term neurological sequelae. So it didn't really change practice. For people that were doing deep hypothermic circulatory arrest, they still did it. But there's plenty of institutions that do a lot more of regional cerebral perfusion and don't do any circulatory arrest. They just perfuse the brain during that time when they're operating the aortic arch and don't worry about freezing down to 18 degrees. So sort of more of a stylistic thing. But important for us to know that we don't do it that often. You know, we do 50 Norwoods a year and then maybe another 20, 30 spatterings of aortic arches and 10 total veins a year. So out of the majority of our cases, most of them don't have circulatory arrest. But there'll be other times where you'll see it. Sometimes the surgeons will just, when they're having trouble with lots of bleeding, after a few pump runs, they still can't get things controlled. They just want a dry field to just go on circulatory arrest for 5-15 minutes, something like that. Where you might hear like really short arrest times. But for the most part, we're mostly doing moderate hypothermia down to 25 degrees and bypass with cardiac arrest, meaning that we gave cardioplegia, we decross-clamp, the heart is still. There are some cases that we do without arresting the heart, just on bypass. So you're just bypassing the heart and bypassing the lungs to make sure you have good oxygenation and blood pressure. But you don't actually have to arrest the heart. And those would be cases of mostly on the right side of the heart. Usually it's our RV to PA conduit exchanges. You can imagine if we're bypassing the lungs, we don't really care if blood's going out the RV and going to the lungs to get oxygen because we have the bypass machine. So a lot of times you can just let the heart beat, just clamp above and clamp below and take out the old conduit and put in the new conduit while things are beating. The one thing that the surgeons always have to be aware of is anytime you're opening up the heart, all this air can rush into that potential space, so you want to make sure no air gets into the heart. And if the patient has a PFO or some sort of ability to shunt, you don't want the air going from the right side to the left side and causing a big air embolism and having your patient come back seizing. So they'll either make sure there's no shunts available with a TE or in a bubble study, or they usually will even be safe, even if they know there's no shunts, put what we call a de-airing needle. So they'll put a needle in the left side of the heart, usually on the most anterior structure, since air is going to rise up and just basically sort of scavenge any air that might be coming in. But those are cases. That you will see that where you'll just get bypass time, and you won't have a cross-clamp time because they'll be doing it on a beating heart. And like I said, every time you have a cross-clamp time, that means the heart's been arrested. So those are the sort of main things. Do you need me for something?
Let's learn it.
So that's bypass time, cross-clamp time, which is synonymous with cardiac arrest time, and then deep hypothermic circulatory arrest, where you're really chilling down to 18 degrees and just, I sort of found it amazing when I learned that you just literally drain the blood out of the baby. I think it's just sort of crazy. The blood's just sitting over there.
It is sort of great.
What's MUF?
So MUF. So MUF is modified ultrafiltration, so MUF. So you guys know it well because that tells you when the patient's about to arrive, right? But there'll be about an hour and a half once it says MUF and centricity, because that means the case is over. So when you're on bypass in general, you take all the blood out of the venous system, you put it to a big venous reservoir, and then you pump that blood from the reservoir into your oxygenator and your de-airer, your debubbler, and put it into the pump and pump it back to the body. During that time, we actually do filter the blood. So we'll hemoconcentrate and try to remove some of the inflammatory mediators that occur with just being exposed to all the plastic in the pumps. And so they will do some ultrafiltration, but it's limited because you're taking it from the venous side, so you can't suck too fast, or you start like collapsing the structures, and you won't be able to sort of entrain air. And you have to keep the reservoir filled a certain amount, or else you'll suck too much and bring air into the system. So we can only do so much filtration, and it's even more limited in pediatrics because the blood volume is much smaller. But cardiac bypass and especially circulatory arrest cause lots of inflammatory problems, capillary leak, hemodilution, cytokine release, all these bad things that make our patients blow up like Michelin babies when they come back here. And we also don't want to expose them to any more blood that we don't have to. And it's sort of a rule of thumb as far as blood exposure goes, that if you're about 15 kilos or less, you're going to get exposed to blood when you go on bypass down the OR. If you're above 15 kilos, sometimes we can do it without giving you any blood products to prime the pump. You can do a clear prime, but in babies or kids less than 15 kilos, the proportion of what a clear prime would be going into their body would dilute their hematocrit so much that it just wouldn't be tolerated. But when you're bigger than 15 kilos, you might not get any blood exposure. So that's a lot of times we have ASDs that are 5 years old that we have closed, and you guys are getting gases that have a hematocrit of 19, and we don't do anything about it because we said, oh, they didn't get any blood in the OR. Let's try not to expose them and expose them to that. Although it's very minor risk, but sometimes we'll try to prevent them from having that. But getting back to muffing. So because of all this capillary leak, hemodilution, volume overload, people said maybe we can do a better job after bypass to hemoconcentrate things and remove some extra water weight. And so modified ultrafiltration is modified because it happens after bypass. So it's when you're done with cardiopulmonary bypass, they actually take out some of the cannula, but not all of them. And what they do is they almost reverse the bypass circuitry. So instead of taking all the venous blood out, running through the system, pumping it back to the aorta, when you do muff, you actually take blood from the aorta. So you're taking high-pressure blood from the aorta cannula and now running it through your ultrafiltration system, where you can be much more aggressive because you don't have a reservoir that you have to keep filled because you have the whole baby or a whole patient as your reservoir, and you're taking from very high-pressure arterial blood. And you can just take all this great arterial blood and filter it, and you can also then Y in the extra blood that's in all the tubing in the bypass circuit, and the blood that's in the reservoir, so that this baby's already been exposed to all this blood. Why not give it back? Well, you don't want to give back a liter of blood because this is going to make the baby have to be on more Lasix for a longer period of time. But if you can hemoconcentrate things and filter it off, then you can give it back. And so that's what muffing is, and that's been shown to really improve lots of different outcomes. I mean, it's been a relatively, especially in the pediatric population, that doing modified ultrafiltration after bypass helps with the inflammatory process, helps with some capillary leak, helps with time on the ventilator and things like that. So that's something that we'll typically do, usually for patients that are under 20 kilos. When you're over 20 kilos, the percent of the circuitry compared to your body doesn't really mandate that you need to do the modified ultrafiltration, because you can do enough of the ultrafiltration to remove some of the extra water weight and some of the cytokines and other mediators when you're on pump, so you don't necessarily need to do the modified after. But if you're under 20 kilos, usually we'll to hemoconcentrate things. So that's the other sort of component of what goes on from bypass to cardiac arrest, plus or minus circulatory arrest. End of the case, you can do modified ultrafiltration. You also have to hopefully separate from bypass. It's another key component, and a small percentage of our patients aren't able to do because of all these sort of effects that the body has from doing all these things. One is the exposure of the plastic and all the inflammation. It surely affects your coagulation cascade. It sort of activates your fibrinolytic process, or the process to break down clots, so you're at a sort of bleeding risk, especially in young kids. We give vitamin K at birth because our vitamin K factors are deficient, and the body isn't able to metabolize and make those factors that are vitamin K dependent right out of mom. So we give vitamin K to help that process, but there's still immature pathways. So that's why bleeding is such a problem. It's not always surgical bleeding, but then you get a medical coagulopathy from bypass, and so that's one of the things that can prevent you from coming off smoothly is a lot of extra bleeding. Surely the effects of arresting the heart and giving cardioplegia or doing circulatory arrest are going to have side effects with when you reperfuse and being sick. So those are all things that sort of play into a patient, separate from the machine and come up here in a relatively stable condition. There's certainly other factors, anatomic residual lesions. Surgeons didn't get all the things they wanted to fix or didn't fix them appropriately. That's why postoperative transesophageal echo can really help the surgeons, manage those things that might prevent the patient from separating. Cardiac stun, we talk about all the time, because that's always what we hope it is. That the heart's just stunned and did not awake well from being arrested and on bypass, and sometimes it just needs a little bit more time, and they might be able to support the patient on ECMO for a few days and let the heart recover. There's also endocrine changes, and you see a lot of the hyperglycemia is associated with bypass. kids have poor thermal regulation, so they can have thermal regulation problems during bypass or thereafter. So lots of things can play into not being able to separate, but those are the main components that we have to operate on all these complex lesions. I talked a lot.
And
hopefully some of them make
it was
sense.
great.
Yeah.
Great. Does anybody have any real quick questions for Gabe?
Anybody? Going once? Have another donor?
It was awesome, Gabe. Thank you so
Thanks,
much.
thank you.
Yeah, that was